Hi, good evening, everybody. Thank you for joining us. Hearing loss is more than an inconvenience. It may also impact your brain health. Joining us this evening are Dr. Nate Bergman. He's the Chief Scientific Wellness Officer for Kemper Cognitive Wellness, and also Dr. Anna Majors, audiologist from Hearing Life in Westlake, Ohio. Tonight, we're going to explore the connection between hearing, cognitive wellness, and also dementia. We welcome your questions as we go along this evening, so please type them in the Q&A or at the chat at the bottom of your screen, and we'll do our best to answer your questions as we go along. If there are questions that we don't get to, we will answer those at the end of the night. So with that, I'm going to turn it over to Dr. Nate Bergman. Go ahead, Dr. Bergman.
Thanks, Val. Yeah, I mean, this is again just an attempt to have a relatively formal but informal conversation with an expert. Thank you for being with us, Dr. Majors. But just in general, just sort of by way of introduction, this year one of our Kemper's focuses is in to bring you information to highlight how sensory inputs are important. Think smell or vision. Today we're going to focus on the ears or the sense of hearing and how it plays a direct role in how the brain stays stimulated, how it stays connected to itself, and how it connects to other things, and just generally resilient. One thing that was still kind of new to me a few years ago is that untreated hearing loss doesn't just affect the basics of communication, but it also uncorrected hearing loss, that is, can increase something called cognitive load. So that's like the amount of work that you're asking a brain to do. And I think sort of frighteningly, untreated hearing loss can accelerate brain shrinkage, brain atrophy. And part of the reason we're having this tonight is the exciting part is that an assessment and treatment really allow us to do something about it now. So with that, I'm going to welcome in Dr. Anna Majors. Thank you very much, Anna. Dr. Anna is an audiologist with one of the Hearing Life Centers locally and somebody who I refer to fairly often. Thanks for being with us.
Yeah, thanks for having me, Dr. Bergman. I'm really excited to share my favorite topic, which is hearing health.
Yeah.
Um, I'd love to start off maybe with a little anatomy lesson to get us going. So if we could pull up that first slide.
Sure. And I just want to encourage everybody, if anybody in the audience there has a question, just type it in the chat. We'll get to it, as we usually do, we'll get to it in sort of in time or in at the end. But just don't feel free not to wait. Just kind of shout them if you got them.
Absolutely. So we've got three parts of our outer ear, our middle ear, and our inner ear. And all of that goes straight up to our brain that does the job of hearing for us. So our ears essentially are just a pathway up to that brain. I want to start off by saying there are two different types of hearing loss that you can have. The first type of hearing loss we have is called conductive hearing loss. And you can think about this in a mechanical way. There's something mechanically wrong with that sound transferring from the outer or middle ear to the inner ear, and then furthermore up to the brain. There's a lot of common causes for conductive hearing loss, and I have some examples listed on that screen for you. Earwax buildup can cause up to a mild hearing loss. Ear infections can also cause hearing loss. And problems with the bones in the middle ear, oftentimes those can become stiff as we age. This problem is actually more common with women. The second type of hearing loss we call sensory neural hearing loss. And that means that we have an issue with the inner ear or the cochlea. In that cochlea, we have hair cells or nerves that transfer our acoustic signal or what we hear through our ears to an electric signal that our brain interprets as sound. So when we have a problem with those tiny hair cells, it is considered to be permanent damage, and treatment for that includes hearing aids, and it can also be communication strategies. And in severe cases, it could be cochlear implantation, which is that device that we wear on the back of our head that transmits the sound signal directly to the brain.
Okay, nice. So you kind of covered the big. Is there one that's like more common than another? Is there one that's common at like sort of an older age? And what are those kind of ages where you start to see these things?
Absolutely. So the most common hearing loss will be the sensory neural hearing loss, and we see that in 1 in 3 adults over the age of 60 years old. It's most commonly seen in the higher pitches, which we will see a picture of a hearing test in a moment here. Um, and oftentimes we can see symptoms like ringing in the ears, hearing but not clearly understanding. Those are most commonly symptoms of that sensory neural hearing loss.
Okay, when like when when dad or honey is sort of like having to, just see him watching videos and everything's really seems loud. Is that, I mean, that's not the only, I mean, obviously if people are needing to turn up the volume, that's one thing. You're saying something different. You're saying people aren't hearing things maybe clearly. It's not just that the volume's up.
Yeah, absolutely. One thing that I hear most out of my patients in their initial assessment is that their loved ones, their family and friends, they're mumbling to them. It's not that they can't hear them, but they think that people are unclear or feel that they're hearing underwater, that mumbling sensation.
Okay, it sounds like people are mumbling to the person with hearing loss. Okay.
Mhm.
Can you just also maybe set the table, because this is not going to be a super long conversation, but we do, we're focused obviously on brain and brain health. How does, what's the current understanding about how hearing loss contributes to Alzheimer's, dementia, and maybe just sort of brain health in general for those that are trying to maybe sort of prevent, which we'll talk about later.
Yeah, absolutely. So it's really important to understand that hearing loss alone does not cause dementia. It does not cause cognitive decline. However, what we do see with untreated hearing loss, like you mentioned in the beginning, is that it increases your risk of cognitive decline due to that increased stress on the brain over time. Hearing impairment and cognitive decline were first linked together over 2 decades ago. So we've known about this for a really long time. And we found that our brain has to dedicate a lot of resources to hearing. When hearing loss is present, the brain has to then shift or reallocate a lot of resources to hear. And that's at the expense of other brain functions, other memory focused or cognitive based functions. But the real scary factor, if you will, is that even with a mild hearing loss, something that maybe you wouldn't find significant to you on a daily basis, that would increase your risk of cognitive decline times two. It'll double that. And
It's a
then
big deal.
the more severe we're talking hearing loss, if we've got a severe to a profound hearing loss, then we're talking that risk will increase fivefold.
Okay. Well, so now we're using words like mild or severe. So I think
Yeah.
those seem like, well, those seem maybe like subjective terms. Can you explain how those are not subjective terms, how those are sort of objective and measurable?
Yeah, that's
Um,
actually going to be your diagnosis. So if you could pull up that audiogram slide that we have on deck. So we measure hearing by placing you in a soundproof booth and asking you to listen to a series of tones. At the top of this picture on the horizontal axis, you can see decibels. This is your pitch, as in a piano scale. This goes from low tones on the left all the way up to very high pitched tones like the birds chirping. And then we want to see how soft or loud you need that level to hear. And that's on our vertical axis. We start at the top with very soft sounds like a whisper to loud sounds like a gunshot or a jet engine. I've put an example of a hearing checkup on the screen. If you can see, the blue X's would be the left ear's results, matching with the red O's, the right ear results. This would be maybe the most common picture I see on a day-to-day basis, meaning we have better hearing in the low pitches and a more severe hearing loss in the highest pitches.
so meaning where this is what a person is able to detect, right? That's in their right ear and their left ear. And then as the pitch is getting higher, they're losing this person, whoever this test was, the higher the pitch, they're losing more of the ability to hear.
Correct. And
Okay.
right on this page, we want all of those marks, the X's and the O's, to be up in that green box, and that would be normal hearing, and that is across the lifespan.
Really? What, I mean, how many how many people well, I mean, you're biased because you're seeing people that are worried, right?
Sure.
Um, more and more, I'm sending people just for general screening. You know what I'm saying? Because it's part of the wellness quotient. You know what I'm saying? It's not just so I guess that brings up, when should so this is how long does a test take just to finish out the audiogram concept?
It takes about a half an hour from
Half
start
an
to
hour.
finish. We measure these tones like I've spoke about, but we also measure your ability to understand speech at a level above your hearing loss. So we want to check on that brain functionality as well.
Okay.
And
When you
Dr. Bergman, oh, sorry to interrupt. There was a question, where on the hearing scale do people with MCI usually mark? Any
people with
idea?
mild cognitive impairment.
Yes.
So hearing loss is individual, right? There's a lot of factors that go into the results that you see. It's a combination of how much you've used your ears over the lifetime, right? If you've been in loud sounds or consistently, it's about genetics. And so there's really no two audiograms that are exactly the same. So somebody with cognitive impairment could have a mild hearing loss. Somebody with cognitive impairment could have a more severe hearing loss.
Or they could have no hearing loss. I mean, we've
Exactly.
definitely sent people over and and that's not what's driving them. So it's like I think about hearing as one risk factor and one intervenable risk, either on the prevention side or on the intervention side. It seems like more and more midlife hearing loss. This is a big study about almost 3 years ago now, as you know, Dr. Majors, that intervening at midlife is you basically ages less than 65. Um, it dramatically reduces the risk of developing Alzheimer's, possibly more so than cognitive reserve, um, close to like exercise, smoking, things that have long been thought of as the major things that would drive Alzheimer's. Hearing is like the number one thing now, at least midlife, which is amazing to me.
Yeah, yeah, and I can piggyback off that. One statistic that we are working on changing is that most people on average will wait 7 to 10 years after noticing some type of hearing loss to come ask me for help. And that's a really, really long time.
Yeah, that is a very long. Okay. I'm gonna I if anybody has more questions about the audiogram or like what's involved in sort of like what Dr. Majors does when she first sees someone, just let us know. I'm sort of interested in, how did people get there? Like what are the things that people have done? A lot of us have gone to concerts or gotten, heard our ear and we leave and we hear our ears ringing. Is it better to have left the concert? Does it matter how long somebody was at the concert? Is it better to only be for half an hour? Does the amount of sound and the amount of time under those loud sounds, do those kinds of things matter? I've been hearing that those are the things that matter, right? Like how long someone's exposed to a louder sound, etc.
Yeah, those are extremely important factors. Again, I'll ask you to go ahead and switch my slide to our keep going. And one more. So while we're talking about hearing protection, the amount of time you're exposed to these sounds absolutely matter. We have a safe duration. It depends on how loud these sounds are. So if we can think back to that picture of the audiogram way at the bottom, we're talking about jet engine level loudness down here where that gun is. You can only be in that level of loudness for a very, very short period of time before causing immediate permanent damage to your hearing. And we're talking 15 minutes maximum a day. As we get into concert level ranges, I've been to concerts anywhere from 90 to that 115 decibel max sound levels. And the more time we're in there, the more permanent damage we're doing. Of
So
course,
what's like the conversation? People are listening on a computer with a volume at medium or just an average conversation. What's the approximate decimal level? Just like not a super noisy restaurant, just a normal conversation in a relatively quiet room.
we're talking 50 decibels.
That's 50 decibels. Okay.
Yes.
And then the danger zone gets 70, 80 decibels start to get danger zone. If you just go to
I
like
would say
Starbucks,
90 decibels is
90
starting to get
decibels.
danger zone. Yeah.
Okay.
A lawnmower for 2 hours. If you've got if you've got a big lawn, we're talking springtime and it's rainy here in Ohio. A couple hours a day mowing that lawn, you're going to do some damage to that hearing if you are not wearing appropriate hearing protection.
Okay, and we'll talk about appropriate hearing protection here in a second, but
Sure.
other things in terms of risks. So we had a question before we started. Somebody asked about like ear pods or different kinds of headphones and things like that. Do those present a risk? I mean, maybe it matters how loud it is, but do just putting in something like these, like the Apple AirPods, do they just by virtue of the fact of how they're designed, do they automatically hurt someone's hearing, or does it matter? Are there sort of dependencies? Does it matter like how loud it is and how long you have it on for, etc.?
General rule of thumb is if other people surrounding you can hear what you're listening to, you're listening at a unsafe level. Things like AirPods, fortunately, do have built-in hearing protection guards. They're not going to let you listen to, say, that 95 decibel sound for longer than 4 hours before they tell you that you're in that danger zone.
Yeah.
A lot of new smartwatches available these days. I'm not sure if anybody's gotten that signal, but they say, "Hey, you're in a extremely loud environment. Please take precaution."
Yeah, I know the Apple Health Suite definitely does. If somebody just has like a either an Apple Watch or an iPhone,
Mm-hmm.
if they're involved or have turned on the Apple Health feature, it will typically as a default.
Yeah,
Okay.
Dr.
and
Majors,
there.
there is a question regarding what you were just talking about with the exams. When is a good time to get a hearing exam if you aren't noticing a huge hearing loss? The
And
gentleman
I would add to
said,
that, I'm going to add to that question. So that's a good question. So like she says, at this time, I have some issues hearing when in a noisy restaurant or if someone is talking very softly. So if you could even just talk about
Mhm.
so there's minor hearing loss, we've talked about major, we've talked about what about even just like the screening, right? Like when is it time to start to look from a wellness perspective, a prevention standpoint? And then if you can answer that person's question specifically.
Sure. So I start usually testing people's hearing around age 60. We have a great slogan: test your ears at 60 years. It's a good reminder, even if you are only noticing subtle difficulties, maybe in restaurant environments, asking for a little bit more repetition, maybe a disagreement about where you'd like the TV volume to be at home. Those are some indicators that it's time to have your hearing checked. We've talked about it in the beginning. Many people wait until it's very noticeable or they have a significant hearing loss to have that hearing checked. But it is very beneficial to have a baseline check done. So that way we can see how quickly this may be progressing and we can track that over the years.
Okay. So if somebody's having any kind of hearing loss, I guess so to sort of also just to amplify, no pun intended, this patient's or this person's question. So let's say, I don't know if this is a male or female, but let's say she goes in, she's got you note mild hearing loss. Is further loss something that can be prevented, or is it just like an inevitability? Like if you do certain things, can you prevent further loss?
Hearing loss is going to be progressive as we age. It's different for everyone. What we can do is minimize our time in these noisy environments. Things we also can do is stay active and social. Our brain enjoys listening and learning. So if you are stopping doing things like going to those restaurants because you don't want to ask for repetition any longer, that is a key indicator that other things are going on.
Okay. And what is just if you can also sort of suss out, so there's like loud sounds hurt hearing, right? They can injure the ability to hear and then sometimes almost, you know, irreversibly injure it if it's loud enough for long enough, like you see on the graphic there. But what's actually happening when someone's having trouble hearing in a noisy environment? They can't focus on the individual that's talking. Like, is that a different problem? Or is it the same problem?
Oftentimes it's because we lose our hearing in the highest frequencies first, and that is the area where we have consonant sounds. So a lot of that clarity is missing. For example, if I said to somebody, I'm going to get a carton of eggs from the grocery store, cognitively, if you didn't hear that S on the end of eggs, your brain is going to fill in the blanks. Doesn't mean you heard it. So you're going to work extra. You're working overtime to do the same job as someone with a normal sense of hearing will have.
Interesting. Okay. So I'm really into so we see a lot of people, and I think we're trying to sort of push the edge on what is thought to be traditionally possible. So we meet a lot of people that do have a mild cognitive impairment. They have not dementia, but they have cognitive loss that hasn't really prevented them from being able to drive or live on their own or do the things they want to do. And then they're focused on sort of maintaining that and not getting worse. And we try to come up with plans. So for on the prevention side from hearing, I see a couple of things here, like, what I might see somebody working at an airport, like the big noise canceling headphones, all the way to, we have a couple people, both on our staff and as patients that like dance at the Cavs games or whatever. And they're protecting their hearing in many cases with something maybe not exactly like this, but is that like, what are you thinking about preventing with devices or earplugs, or can you just kind of talk about prevention and things like that for a while?
Yeah. So there's some, like you said, there's some things that we can manage. There's some risk factors we can change. There's some we can't. So things we can't change, age, our genetic makeup. But the things we can change would be hearing healthcare, wearing your hearing protection when you need to, good exercise to prevent other factors. You want to keep up on social engagement, whether it be the newspaper games or your bingo class every Friday. Those all help with not only hearing, but play a big factor in cognition.
Okay. No. Okay, so we've talked about the assessments, we've talked about risk factors, we've talked a little bit about prevention, and then ways to sort of continue to promote um, sort of positive hearing health, if you will. There's another situation and scenario that seems that to me at least, it's almost as common as just hearing loss itself, which is ear ringing, which is tinnitus. Can you talk? I mean, and I'll just tell the group here. We had I sent Dr. Majors a patient, probably 3 years ago, maybe 3 years ago at this point, and he has tinnitus. Didn't really have much hearing loss, had minimal hearing loss, but he had tinnitus. Got hearing aids from you, and his tinnitus actually improved a little bit. Like, it was noticeable. And I've always thought, okay, tinnitus, ear ringing is like something that just doesn't improve, and like that's sort of when I got schooled by the ENT doctors and stuff, like that was the going thing. Is that like, can you first of all sort of explain what tinnitus is, and
Mhm.
if what I learned 14 years ago or whatever, 15 years ago in medical school is still the truth?
Yeah, absolutely. If we could bring that tinnitus scream up, thank you. So we all have certain sounds in our ears that may happen. Maybe a high frequency buzz, cricket sound, or a low hum. When this becomes tinnitus is when it lasts longer than 5 seconds on a semi-consistent basis, meaning daily, weekly, and it's something you're paying attention to. Right now, we do not have a solid cause as to why this happens. We have things that we know are risk factors, including different medications you can take. Your diet can affect this. Exposure to loud sounds. So if you do get caught, next to a firecracker, you're going to hear some ringing in your ears. And the most common one would be hearing loss. Right now, the only treatment available for this ringing in your ears would be the use of hearing aids. Right now, we do think that because the hearing loss is in the highest pitches, our brain is triggering this pathway to stay open, to stay alive, saying, I want to hear this high-pitched sound. Now, when we reintroduce that sound naturally through your ears, the brain is able to no longer make that pseudo sound. It's almost like we're canceling things out, like a yin and a yang. If we can get those wavelengths the same, then you no longer hear it. And there are different outcomes with this. Some people notice that when they wear their hearing aids, they no longer hear that ringing at all. Many times people will say, I still hear it, but it is not bothersome any longer. There are chances that you still wear hearing aids and the ringing is still present.
And
Now,
so we had a super interesting conversation not too long ago, you and I, about giving frequencies back. Like, and I thought that was like that was news to me. Can you say a little bit more about what you just give people context and what you mean by that? Because I believe the context was for tinnitus.
yes, absolutely. So if you have a hearing loss at the highest pitch that we test, which is important for speech understanding, that would be at 8,000 hertz. That's where right up where our bird is. You can see on this patient in particular, he has a severe hearing loss at this pitch. It goes all the way to the bottom of my graph. Now, without hearing aids, the brain is triggering almost like an alert system saying, we don't hear this sound anymore. Can we keep this frequency available for use instead of closing down this pathway? Now, that triggers the brain to play that sound. It could be constantly or it could be intermittently. And most oftentimes we hear it in quiet when our brain is less distracted, at night or in the morning. Now, with the introduction back, hearing aids are prescriptive devices, just like eyeglasses. You have a prescription for hearing aids. We reintroduce that 8,000 hertz tone through those hearing aids directly into your ears. And many times that satisfies the brain.
That's so interesting. I'm fascinated with that. So yeah,
Dr.
I think we have.
I was just going to say, Dr. Majors, you have a question
Yes,
regarding does
so
diet
I was
affect
I'll
hearing?
get to that question. Thank you so much.
Yeah.
I'll for sure get to it. So yeah, we just had somebody in here in clinic that really had that issue, and I'm now we're going to be going after tinnitus differently than we used to. Um, so I've you know I've seen a lot of different things about tinnitus, and then I want to go back to the prevention thing because oftentimes when I've sent people when they have tinnitus, they don't end up having an abnormal hearing test, and so then people are asking, what can we do? So, like Val was saying, Rose has asked, does diet affect hearing? One of the things that you'll hear, and I believe there's literature for it, but we don't know why, things like higher diets in magnesium or actually taking magnesium could prevent, at least episodically. So if I go to a concert, maybe I take or eat a bunch of magnesium. Does diet impact hearing? Is there a way to prevent anything to your knowledge with diet?
Diet specifically, we can look at things like that typically aggravate that ringing in the ears. So what I see diet wise is if you have nicotine in your system, caffeine, not enough potassium, not enough water, too much or too little salt intake, all contribute to a healthy ear. Our ears are made up specifically of three things on the inside. That's water, potassium, and salt. And if we have too much or too little of any of those things, it can aggravate the ringing or tinnitus in our brains.
Oh, very interesting. Very interesting. Yeah, keep the questions coming. Some people are
Dr.
coming in the
Bergman,
chat.
did you see the other question about, and this is probably for both of you, does it matter if you use a Bluetooth earphone device or a wired versus one that's wired?
Yeah, do you have a sense? Do you have a preference? Does it matter? Bluetooth or the old? You can't even find the wires anymore, but you know what I'm talking the old way to.
For headphones, no preference. The newer, of course, the better, just because it has those features that will automatically protect or safeguard those higher level or higher intensity things that you're listening to.
And do you have a preference? Earbuds that go in the ear, things that sit outside the ear?
I do not. No preference on that.
Okay, very good. And then there are more and more you see options for sort of like bone conduction, and that there's like hearing, there are listening devices, sometimes headphones that also employ bone conduction. Do you know what I'm talking about? You probably
I
know
do,
very
yeah.
well what I'm talking. Can you explain a little bit that what is that about? Why would those things be necessary? When do those come up?
Yeah, we can hear through our mastoid bone, which is right behind our ear. So if you remember those tuning forks, same kind of mechanism there. You strike a tuning fork, it vibrates at a frequency. We do the same thing with our ears behind there. Um, when it comes to headphones, it really is just a comfort thing. Some people have different ear sizes. I know for me, it is uncomfortable for me to wear things that are completely in the ear. I do prefer things that go over the ear. There's new devices out now that sit again behind your ear with a great sound quality. But that's all about personal comfort.
Yeah. Okay. All about personal. Okay. Um, Okay, so I mean, maybe you can give us the latest on kind of hearing aid technology. I remember I was at a transformational technology conference maybe 7 years ago out in Palo Alto, California, and it was really interesting. One of the most amazing talks of the night was this fairly new hearing aid company that it was like having an external brain. I mean, it was doing stuff. Can you kind of take us into how hearing aids have changed over the last 5, 10 plus
Mhm.
years and why they're probably better now than they ever have been?
Yeah, you hit the nail on the head there. We have really progressed. You know, our old style hearing aids 15 years ago were based on amplifying sound, and that's really all we could do. We could amplify sound, and now we have the ability to have our hearing aids almost have a brain. The hearing aid knows about hearing processing. Your brain processes hearing in two different locations. It's one place where you're focusing or attending to conversations. The second place is passive, or what's going on around you that you may not be focusing on, but you still are hearing. Hearing aids are able to separate those two things now, allowing us to work directly with that focus part of the brain and sending clear signals. We'll never be able to completely take away background noise. That is part of hearing. We all hear it, but in the advancements in technology, we are able to drastically cut down on annoyance of background noise and making sure that speech signal is clearly heard through the noise going on around it.
Okay.
Super big topic this year, of course, is artificial intelligence. We talk about it a lot, and it's a huge improvement in hearing aids as well. A hearing aid computer knows over 200 million sounds. Probably can identify those sounds faster than you and I could.
Yeah. So maybe we can go back to this anonymous question about when's a good time to get a hearing exam. So if someone's sitting in a noisy restaurant or if and they're having trouble hearing that, or if someone maybe is talking very softly, although that seems more just of like an amplification question. Uh, but does is what you do now differently when someone's coming in? It's like I could normally, like if it's just me and my wife, I no problem. If it's me and my brother, no problem. But if I am in a noisy environment, then I'm find myself like I can't. Do you treat that differently than someone who just is just I can't hear it's hard for me to hear everything. Like how does it work? I mean, are you programming the hearing aid differently? Do you know what I'm
We
saying? Or is it a
do.
different hearing aid choice? That sort of thing.
Yes.
Like
Yes,
how do
there
people know
are.
if they're getting ripped off? But here, like, hey, that'll be 7,000, that's five. Like, what
Yeah.
difference does it make? Why do I need to get a better hearing aid versus a worse one, but more
So
less
right
expensive one?
Yeah, right now, every hearing aid on the market, as long as you get a reputable company, will work great in a quiet room with nothing going on in that room, but maybe a one-on-three conversation. The smarter the hearing aid gets, the price tag typically does go up a bit, and that you're paying for the ability to hear more effortlessly in noise specifically. Um, there's a variety of different types of hearing aids just to match the variety of different hearing losses out there. Some people may need more power while other people need more clarity. And it's a balancing act of both. Just like I said with the eyeglasses, you have a prescription, and that's what we have once you come out of that hearing test booth that we can program into those hearing aids, and we verify that that prescription is happening in the ears, therefore transferring to the brain.
Okay. We're winding down on our questions, which is great. We're getting through everything. I think the last sort of big question that I have is, we talked about hearing assessment, prevention, some of the things that you can do. Like I use a ZOUND, Zound. That's the name of the product that was recommended to me by one of the people that works for us. And I found them effective. I used to use the sticky throwaway ones, and I'm always frustrated when I go to a concert, I go to a wedding, and I forgot them. I'm always kicking myself because it feels like I'm getting that, you just feel that you can feel the impact, and I imagine I'm getting brain damage every time I hear these loud sounds. So I guess there's hearing aids, and then you mentioned at the beginning that for very profound hearing loss, there's a cochlear ear implant.
Mhm.
Right? Can you just explain when that might be necessary, and if you do know of any connection with dementia or brain health, can you just talk about the considerations for a cochlear ear implant? And I'll put up the picture of the cochlea one more time while we're.
Yeah, thank you. Cochlear implants, again, have improved tremendously since their conception. They are no longer a solution that is just for significant to profound hearing loss. But one thing that we consider when we're speaking about cochlear implants is how clear the sound is getting to your brain. So there are instances that even when the levels of speech or sound that you're listening to are loud enough for you to hear it, those sounds remain unclear. I can relate this to a broken car stereo. So if you've busted your car stereo and you turn it up, that volume will still increase. The speaker system still does not sound clear or crisp like you want it to. So in the event that that is the case, a cochlear implant is the top solution to improve clarity when our brain cannot do it on its own. So in fact, we are skipping the damaged parts of your ears and then stimulating the brain directly. So you make a variety of different pictures on this audiogram, and some people may be better suited for hearing aids, while others would be better suited for a cochlear implant based on the level of clarity the brain is able to produce on its own.
But does this audiogram show you clarity? It's like, how do you come down to clarity? Like, what's the metric, if you will, for clarity?
So we would present a speech sound louder than your hearing loss. So for example, if this was your hearing loss, I would want to present it above those marks. Okay. That way I know that you're hearing them well. And I would ask you to repeat a list of 20 words. Say you're only able to understand 3 out of those 20 words. Then we have a significant issue at the level of the brain where it is no longer able to clearly interpret sound.
Okay.
Another patient may have the same picture, but when I turn those words up and have them repeat the same 20 words, they'll get a 20 out of 20, meaning that that level of atrophy in the brain isn't as significant, and hearing aids will be a better solution.
Okay, interesting. So really part of it is the sort of the challenge of the brain's interpretation of the signal, which is probably beyond the science of this conversation, but it's super interesting how sound waves go into, they take into basically beats to electrical signals, then to be interpreted by the brain. There's a lot that has to go right there, and that's pretty small. That's pretty small things, and they were supposed to work for our whole life. It's amazing. Human body is amazing.
Absolutely.
Okay. Any sort of final thoughts, any final questions from people? Usually we have about 45 minutes for this. We have about 5 minutes left. If anybody has questions, we're taking them. If not, if you have any final thoughts, Dr. Magers. If not, I bet Kristen Kemper has some final thoughts.
Well, I had a question actually. Do you do the wax removal at your clinic?
Absolutely. Yes, we do. There are some factors that may prevent us from achieving that mission. If you are somebody that is on blood thinners or similar coagulants, then we need to have it done at a hospital or your primary care doctors. Typically, we do it in the office, though.
Okay.
Anybody else, any last minute questions? Throw them in the chat. Otherwise, I'll let Kristen's going to wrap it up.
I don't see any questions. Well, thank you everyone for joining us tonight. I think we all don't like to think about hearing until we have a problem, but just like brain health, get checked early. I would say before you're 60. And And is it true, Dr. Majors, that you can, when you're younger, let's say you go to a concert at 25 and you know you've overdone it, you've damaged. Is it true that it does regenerate versus when you're 70 and it doesn't regenerate?
That is true. It will regenerate for a certain period of time. Once that damage is done, it's done. So we may not see it when you're 25, 30, 40, but I guarantee it'll show up on that testing when you're 60, 70, 80. We'll see some damage there.
Great. Yes. So I would urge everyone to do it earlier, sooner than later. We used to get tested in the doctor's offices, but a lot of doctors don't do that anymore in the 10-minute visit or even the annual checkup. So I would urge you to get checked early. Thank you all for joining us. If you have any questions, and you're a member, you can message us in the portal or Dr. Bergman directly. If you're not a member, please call us at 216-337-1400 and schedule your personal Ask the Doc with Val. Thank you all for joining tonight.
Thank you.
Bye-bye.
Thank you, Dr. Majors. Thanks.
Thanks.